Hello, my name is Angie Bogner, and I'm doing my clinicals at an Integris Family Care practice in Edmond, Oklahoma. The patient case I'm presenting today is BB, a 68-year-old Caucasian male, here by himself with a complaint of nocturia. This patient is knowledgeable about his health history. BB's chief complaint is nocturia that started about 1 month ago. About 2 months ago, he stopped taking his Flomax because he was no longer having problems. In addition to waking up 3 to 4 times per night to urinate, he reports a feeling of incomplete emptying of his bladder, frequency, urgency, weak urine stream, and dribbling after urination. 1 week ago, he developed dysuria. BB reports some frequency and urgency during the day, but it is not as bad at nighttime. Nothing seems to make his symptoms better or worse, but he's only tried reducing his fluid intake to decrease urinary frequency. I chose this case to do my presentation on because I have found that I make assumptions when gathering my HPI. I assume that the patient is going to provide all the symptoms they are having, especially if they are related to the same body system. Unfortunately, this is not true. In this particular situation, the patient did not associate his other symptoms with the nocturia. The case was a good reminder to ask the question, even if you think you already know the answer. It also required treating more than one problem, as the BPH more than likely caused the UTI. I also chose this case because I think patient education is directly related to positive patient outcomes. This patient needed education on Flomax and why it is still needed. BB did initially provide a lot of information. His only complaint was nocturia. He did not provide the information that he stopped taking his Flomax. That wasn't even identified until later in the visit when reviewing his medication list. He didn't report the urinary retention initially, the weak stream, or dribbling after urination. In my mind, all of these symptoms are related to one another, but to him, it was the nocturia that was the most bothersome, so that is what he wanted treated. The other symptoms were just an annoyance. Past medical history includes hypothyroid, GERD, herpes simplex, and BPH. His preventative care is up to date. Family history includes breast cancer and cataracts, diabetes, heart disease, prostate cancer, RA, lupus, and these are all in his mom, dad, and grandparents. All parents and grandparents are deceased. His social history, BB is married with 1 adult child and 3 grandchildren. His household consists of his wife and 2 dogs. He's a retired police officer and attends a local Baptist church. He has a good support system from his wife, son, neighbor, and church family. He's a non-smoker, has never used drugs, and drinks once or twice per month. When he does drink, he has 2 or 3 beers. He eats a balanced diet, 2 meals per day, and 1 protein shake per day. He has a couple of snacks, usually consisting of nuts, celery, carrots, grapes, watermelon, or a protein bar. He exercises 4 to 5 times per week and includes walking, running, and lifting weights. BB feels safe at home and wears a seatbelt when in a vehicle. His review of symptoms, he denies unintentional weight loss, fever, chills, or pain. He doesn't have chest pain, palpitations, or peripheral edema. Denies cough or shortness of breath. No abdominal pain, nausea, or vomiting. He does have dysuria, frequency, urgency, nocturia, weak urine stream, dribbling, and urinary retention, but he does not have flank pain, discharge, or blood in his urine. He denies heat or cold intolerance, difficulty swallowing, voice change, hair loss, or brittle nails. His objective assessment was relatively unremarkable. His vital signs are normal, within normal limits. His BMI is 28. His bladder was slightly distended, but after urinating, we no longer felt it was distended. Otherwise, his assessment was normal. His differentials, UTI, due to his symptoms of frequency, urgency, dysuria, BPH is my second differential. That was the symptoms that would support that are urgency, frequency, dribbling, nocturia, and retention. His symptoms also started after he discontinued the Flomax. Overactive bladder was a differential, and the symptoms of urgency and frequency would support that. Neurogenic bladder was another differential. The UTI frequency and dribbling would support this diagnosis. The patient's UA was positive for leukocytes and nitrites, so he'll be treated with antibiotics. His BPH and urinary retention also need to be treated, as that was likely the cause of the UTI. The resources I used were Family Practice Guidelines book and the UpToDate app. Our plan for the UTI, we obviously did a UA that was positive for nitrites and leukocytes, and was prescribed Bactrim DS twice a day for 7 days. We chose this over macrobid or fosfomycin because the patient has successfully taken it in the past and it's relatively inexpensive. For BPH, we restarted the Flomax 0.4 every day at bedtime. We didn't really consider the other BPH treatments as he had been on Flomax previously and it was effective. We will consider a post-void ultrasound for urinary retention if the patient is still having problems with this at his follow-up. These medications are currently first-line drugs in treating their diagnosis. Education, we instructed him to empty his bladder every 2 to 3 hours, increase his fluid intake to 72 ounces per day, try not to drink after 8 p.m. to decrease nocturia, avoid caffeine and alcohol, especially in the evening, complete the full course of antibiotics, even if he feels better before he's finished with them, take the Flomax at bedtime due to the hypotensive side effects, do not take Cialis or Viagra while taking Flomax due to the hypotensive side effects. Take Flomax every day, even if you don't have symptoms. If you don't have symptoms, it means the medication is working. Don't discontinue any medications without consulting your provider first. Follow-up will be in 3 weeks to ensure symptoms are improving and to see if we need to adjust our treatment plan. A holistic approach, Gene Watson's caring theory, is about taking care of the whole person, mind, body, and soul, as they are all intertwined. If you don't have a balance in one area, it can cause an imbalance in another. The curative factor that I used frequently is practicing learning and teaching. Not only can this be regarding continuously learning in your area of practice, but learning what your patient wants for their health and finding out what their goals are. Listening to your patient is one of the best tools you can utilize. You'll obviously be listening to their words, but you should also be paying attention to their body language as it tells a whole story on its own. Education is very important in healthcare. Taking the time to teach patients about their medications, their disease process, the symptoms or side effects they might encounter, or what to do about them will greatly increase the patient's compliance with treatment and improve their outcomes. I use this curative factor with my patient by listening to his concerns. His biggest concern was nocturia. Educating the patient on how this nocturia was related to his other symptoms helps the patient understand why he needs to continue his Flomax, even if it seems like he doesn't need it anymore. I included the patient in the treatment plan by outlining the treatment that I would suggest and ensuring that he was on board with that treatment. The ultrasound we discussed together, and he would like to try the medications before doing the ultrasound. I also used a lot of education regarding the things that I've listed above, and we went into detail about some of those, including why we shouldn't discontinue medications without talking to a provider. Trying to address other things besides the chief complaint helps develop a relationship with them and allows them to feel more comfortable discussing sensitive topics with you. Thank you and have a blessed day.